This is PediaCast.
Welcome to PediaCast, a pediatric podcast for parents. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast. It is a pediatric podcast for moms and dads. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 532 for February 14th, 2023. We're calling this one Long COVID in Children and Teenagers. I do want to take a pause before we get started on today's topic and just say Happy Valentine's Day to all of you. It is February 14th. And at least here in the United States of America, it is the day that we celebrate love. And so I just want to wish all of you a happy day. Happy Valentine's Day. I'm not sure if this is a U.S. only holiday or is this something that is celebrated throughout the world. I just don't know. And probably need to look that up. Seems like something I ought to know. But anyway, if you're in the U.S., happy Valentine's Day. And if you're not in the U.S. and you celebrate it, happy day to you too. So it has been a while since we covered a topic related to the COVID-19 pandemic, which in all honesty has been a welcome break. As you know, there for a while, especially in 2020 and 2021, it felt like we were all COVID all the time on PediaCast, much like every other media source. And you most likely talked about COVID amongst yourselves at home, probably daily during those 2 years. And then 2022 brought Omicron, lots of natural immunity from infections. We also had vaccines and just far fewer hospitalizations and deaths thanks to those vaccinations and to natural immunity as well. And that year also saw some new medications aimed at killing the virus. Here we are in 2023, and there is one aspect of the pandemic that continues to be an issue for adults and teenagers and children, and that is this idea of long COVID. Now, thankfully, long COVID is relatively uncommon in kids and teenagers. We don't really have a great idea of how common it is, to be honest with you, because there may be some difficulty in diagnosing it. You know, sometimes they're mild symptoms that still impact your life, but maybe they're not enough for you to go seek medical care. So those folks, it doesn't really get identified. We do identify the more severe cases of it. But if you look at different studies, it can range anywhere from 6% of children and teenagers who have been infected with COVID-19, all the way up to 60% can have some symptoms of long COVID, according to other studies. So that just means we don't really know how common long COVID is. But when it happens, it really can impact a child and their family, their quality of life. It can get in the way of academic success and sports participation. It can be super frustrating for kids, teens, and families who are affected because they just have these symptoms that just sort of linger. And just to give you a little bit of a preview, the symptoms that we're talking about tend to be a chronic cough, fatigue, just tiredness, achy, maybe feelings of depression, sort of brain fog. These are the kind of physical and mental symptoms that we're talking about with long COVID. And we'll go into a bigger list and a longer explanation as we move on with the program today. That's what we're going to do is dive into long COVID with a conversation that explores the definition, the potential causes, risk factors for developing long COVID, again, the typical symptoms, how it's diagnosed and treated, how long it can be expected to last, and we'll share some helpful tips on preventing the development of long COVID following an acute infection with the virus. So lots coming your way today, and we have a terrific guest joining us in the studio. Dr. Eric Mull is a pediatric pulmonologist here at Nationwide Children's Hospital. Before we get to him, let's cover our usual quick reminders. Don't forget you can find PediaCast wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Radio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. Also, please consider leaving a review wherever you get your podcasts so that others who come along looking for evidence-based child health and parenting information will know what to expect. We're also on social media and love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. We also have that contact link at PediaCast.org if you would like to suggest a future topic for the program. And then I do want to remind you the information presented in every episode is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. If you have a concern about your child's health, be sure to call your healthcare provider. Also, your use of this audio program is subject to the PediaCast Terms of Use Agreement, which you can find at PediaCast.org. So let's take a quick break. We'll get Dr. Eric Mull settled into the studio, and then we will be back to talk about long COVID. It's coming up right after this. Dr. Eric Mull is a pediatric pulmonologist at Nationwide Children's Hospital and an assistant professor of pediatrics at The Ohio State University College of Medicine. He's here to talk about long COVID in children and teenagers. But before we dive into the topic, let's extend a warm PediaCast welcome to our guest, Dr. Eric Mull. Thank you so much for stopping by today.
Yeah, thank you, Mike. Thank you for having me here. I think it's an important topic, and I'm happy to talk about it.
Yeah, it is an interesting one for sure. And I almost feel like long COVID is this term that's inside a box, and I can't quite grasp exactly what it is because you hear so many different things. And as you know, with the pandemic, there really has been a lot of misinformation out on the internet. So it's like, what's real, what's not real. And so I'm really happy to have a pediatric pulmonologist to talk about this because you actually see the effects, the long-term effects of COVID after infections in your clinical practice. So I think a good place to start would be, what is a definition? Like, what do we mean when we say long COVID?
Well, you're exactly right. There's a lot of confusion out there, and it doesn't help that there's so many different names for this type of condition. In the literature, I mean, we call it post-acute sequelae of COVID, meaning that it's symptoms that are residual, new onset symptoms, or symptoms that have been fluctuating, either waxing or waning after an acute infection with COVID. By definition, there's not a lot of great literature out there to support one set definition, and depending on where you look, there's different definitions. Here in the United States, based on the CDC, it's residual symptoms lasting 4 or more weeks after an acute infection. But the most in-depth definition of this condition is actually from the World Health Organization, where they classify it as a diagnosis of exclusion, meaning that no other disease entity can explain the symptoms that are presenting in a patient that we're taking care of. It typically is 3 months after an acute infection. There has to be at least probable or definitive cause of infection of COVID, and the symptoms that are presenting with have been lasting for longer than 2 months. And that is the most definition.
Yeah. So according to the World Health Organization, if you go out, you said 3 months and you're still having symptoms and they're lasting at least 2 months, then that's when you would start to call it long COVID.
Yeah. And it doesn't have to be necessarily symptoms that you had during your acute infection. They define it as 3 different components. One is new onset symptoms, fluctuating symptoms, meaning that they're waxing or waning, or they're persistent symptoms that were present during your acute illness but are still lingering on after viral clearance.
And we'll talk about the most common symptoms that would be associated with long COVID in just a few minutes. Is this something that is unique to COVID, or do we often see long-term effects from other upper and lower respiratory tract infections?
To the best of our knowledge, I mean, this is something that has been relatively unique to this disease process. We have children very commonly during the respiratory season that have RSV or rhinoenterovirus, very common viruses that can cause problems in our children population. And even before COVID, coronavirus was a known complaint of children that have respiratory illness, bronchiolitis, but we don't typically see a lot of residual symptoms following that acute illness.
Yeah, very, very interesting. So how common is this condition?
Well, a lot of the literature is actually focused on adults. Most literature in the medicine world is focused on adults, but it's a really rare condition. So first off, having acute COVID, almost 20% of children are asymptomatic, so they may not even know that they have symptoms of COVID. And with following an acute infection, there's really two main things that we worry about for long-term consequences. One of those is multi-inflammatory system in children, MISC, and the other one is long COVID. The prevalence of long COVID really depends on which paper you're reading or which one you're reviewing, but it could be anywhere between 6 to 60% of children.
Yeah. So that's a huge range depending on the study, right? So some of them, again, between what were the percentages again?
So it's between about 6 to 60%, depending on which paper you're reading and how long the sample or how large the sample size was of that study.
Yeah. And so it's really hard when there's a condition that almost everybody has, right? I mean, it's easier when you have a nice slice of the population and you can see how many people have a particular complication. But when it's something as ubiquitous as COVID has been, that does make it more difficult to get firm numbers, right?
Yeah. And the way that it presents, I mean, there could be over 200 different type of symptoms, and it's across multi-organ systems. It's really a constellation of things. And what makes it hard is it truly is a diagnosis of exclusion.
Yeah. Yeah. So you want to make sure that there's not some other medical process, health issue that could be contributing to the symptoms. Who is at risk for having this happen to them? Is there a profile of a person who may be more likely to experience long COVID?
Yeah. So it can happen with anybody who's had the disease process. Typically, what we've been seeing in our clinic, as well as what has been confirmed in the literature, is that you'll see it with patients that had more severe acute disease. So when they were having their acute illness, they had more severe symptoms, requiring hospitalization, requiring treatments of antiviral, oxygen, steroids. We're also seeing it more of a linear thing. So as the older you get, the more likely you are to have long COVID symptoms. And then also the female population also is more at risk.
Okay. And what about vaccinated versus unvaccinated? Does that seem to make a difference at all?
It does. So vaccination has been shown to help and reduce long COVID symptoms and complaints. And even children that have had the vaccination that have long COVID, typically their symptoms resolve sooner than children that have been unvaccinated.
Very interesting. So would a vaccine help even? So let's say you have an acute COVID infection and then you go on to develop long COVID. If you get vaccinated at that point, does that help the long COVID get better, or is that a done deal at that point?
It can help it. There's not, once again, because this is such a relatively young disease process. I know 3 years seems like a long time since the beginning of the pandemic, but we've been studying conditions since the beginning of time and recording of medicine. So this really is a new and young disease process.
Yeah.
So what we're seeing is that the vaccine can help with symptoms. What we're also seeing is that, that COVID now that we know can cause repeat infection and recurrent infections over different viral seasons, that this may prevent recurrence or return of long COVID symptoms.
Yeah, that makes sense. So if you can definitely get COVID more than once, and plenty of people have had that happen to them. Each time, hopefully, you've got a little bit more of a baseline immunity to be able to fight it off. I guess it would depend on how close together those infections are. But getting that vaccine can help prevent future COVID infections, which would help prevent future episodes of long COVID, because long COVID doesn't necessarily last the rest of your life, right? There's usually a limited time that it lasts.
Yeah, I mean, the prognosis for this condition is fairly good. Most symptoms in a patient probably resolves around 12 weeks after onset of symptoms, or at least diagnosis of long COVID. So we typically see a resolution of symptoms after a few weeks.
So let's talk about those symptoms. What exactly is possible that would be caused by long COVID?
Yeah, so once again, I mean, it really is a constellation of symptoms that cross different multi-organ systems in the body. You can have cardiac symptoms, including palpitations, variation in heart rates, chest tightness, chest pain. Dyspnea, which is shortness of breath or discomfort with breathing, is one of the most common complaints. You can also have coughing, a lingering cough. You can have anosmia or lack of smell, lack of taste. Brain fog and fatigue are also very common too as well. Difficulty concentrating, difficulty sleeping too as well. And then as we're seeing with acute infection, GI complaints can also be common too as well. Persistent loose bowel movements or nausea and upset stomach.
Yeah. And I would imagine that there is also kind of a mental health component just because these symptoms are present from COVID and lasting so long. And we all sort of have a national trauma response to COVID. So do we see anxiety, depression, those kind of things along with it, which may be secondary effects?
We do. And so there also has been literature out there, too, looking at the psychologic and anxiety effects of this disease process as well as the pandemic. And some of the findings are very similar to post-traumatic stress disorder with different age groups, especially our adolescent age groups that have been at least cognizant of the beginning of the pandemic and then also going through the infection and seeing what it was like prior to having the vaccine and just all the news and trauma that was out there.
Yeah. What causes the cough that lasts so long after some of these viral infections?
So I describe it with my patients and my families as kind of a hyperinflammatory state. So you have different receptors in your lungs that can be aggravated and irritated, and sometimes we just need to reset those. When we have an acute infection, it's natural to have a cough up to 2 to 3 weeks after an acute infection. It's the body's natural mechanism to clear out secretions. But when we're having such persistent symptoms, it could be one either related to chronic irritation of the receptors in your lungs versus maybe even a habit developing too as well.
Mm-hmm. And then what do we think causes these symptoms? Do we know?
So the pathophysiology or the cause of these is still unknown at this process. It's believed to be inflammatory mediated, kind of like MISC, the other component of having a long-term consequence of COVID. But that process is slightly different, but this one is believed to be related to different type of inflammatory markers that just remain active, such as cytokines or interleukins. These are things that your body's produced to promote an inflammatory response to kind of treat infection. But once that infection is done, things should shut down and go back to normal. But we've been seeing that those cells and components are still activated.
Yeah. We've talked before in this program about COVID's effect on the heart and causing myocarditis in some folks. And then that can lead to a little bit of a degree of heart failure, and that can lead to a little fatigue. Do we think that much of there's primary organ damage that can be attributed to this, or is it all more chemical mediated?
So the chemical mediated does lead to primary organ damage. So inflammatory markers can make the blood-brain barrier looser, leakier, can also make the blood-lung barrier more looser and leakier too as well, leading to infiltration of inflammatory markers into actual tissue, causing changes of the cell line, causing destruction. The myocarditis component is related to like pro-fibrotic components, meaning that your body is more prone to make clots and make the blood thicker, which make it difficult for the heart to actually do its job appropriately. And so there is true end organ damage that can be related to acute COVID infection and long COVID.
And then as the body fixes the organ damage, then the symptoms of long COVID go away. Again, this is not the only mechanism, but yes, it is a contributing factor, so to speak. You talked about this being a disease of exclusion. Again, we want to make sure that there's not another disease process that possibly would need to be treated. This is in the medical world, we call this a differential diagnosis. What other things can cause symptoms that are similar to long COVID that we would want to make sure is not going on?
Yeah. So, I mean, we've already touched base a little bit on a few different aspects. One is the psychologic and anxiety component of having acute COVID, as well as actually living through the pandemic, leading to different types of complaints. Anxiety has a lot of different impacts in the body that can create real somatic causes, such as chest tightness, shortness of breath, chest pain, all of that and above. Other things to consider are one, that multi-system inflammatory syndrome in children, the MISC, which can present very similar to long COVID, but there's different components to it, including active fever, active inflammatory markers in blood work, as well as a recent COVID infection. This typically is about 2 to 6 weeks after an acute infection, where long COVID is weeks to months after an acute COVID infection. And then, of course, there's other aspects as well. A lot of our children that we've been treating in the clinic have also had underlying childhood asthma that just haven't been diagnosed, or other issues too as well that we've just been weeding out through our workup.
Yeah. What does that workup look like? Like, what can someone who, you're concerned that you have long COVID or your child has long COVID, and you're trying to exclude other things as possibilities, what sort of diagnostic testing do you do to figure out that it is long COVID?
Yeah, here at the Nationwide Children's Hospital in our pulmonary clinic, every patient that comes to our long COVID clinic, we do a few tests. One of them include a 6-minute walk test where we actually have them walk with one of our respiratory technicians or therapists, and we actually see what changes are going on in their heart rate, as well as if they're having any desaturations in their oxygen in their blood, as well as recording symptoms that are actually presenting while the child is walking. After that, they'll come up to clinic. We'll also do pulmonary function testing where we actually have them breathe through a device that allows us to look and see if there's any obstructive process, meaning is there any changes that have causing either air to be trapped in the lungs, or if there's any restrictive process, meaning that the lungs can't fully inflate. And then we'll also get a baseline x-ray too as well to make sure that there's no underlying lung pathology that we're missing.
Yeah. And none of those things are uncomfortable. So kids are going to do fine with the workup, right?
Yeah. None of it is invasive. The pulse ox is a sticker and it's walking down the hallway. The chest x-ray is just a picture. And the pulmonary function testing, we actually have fun games, including blowing out candles, slaying a dragon. It's a computer system and we make it fun for the children.
And then I would imagine if you had particular concern in an individual patient that there could be something else going on, you might do other things like an EKG, blood work to rule out other things that maybe not in all kids with symptoms of long COVID, but if you, if getting the clinical history, you're worried more about heart failure or something else, thyroid problems, then you're going to be doing a little bit more.
Yeah, exactly. And one of the most common complaints as mentioned was the dyspnea or that shortness of breath, which is a lot of the reason why we see the patients in COVID clinic. And depending on what we see, the most common abnormality can be with the 6-minute walk test, which includes an elevated heart rate. Children's resting heart rate should be anywhere between, about 50 to 100, maybe a little higher depending on the age. But we're seeing heart rates that go instantly from 60 to maybe up to 140, 150. And that could be representative of a dysautonomia or something going on with the heart. And at that point, I would do an EKG and refer to cardiology for an echocardiogram and workup.
Yeah, sure. So let's say we've done these things as needed, and we really don't find anything, and we kind of then settle on that. We've excluded other things. That's what we mean by diagnosis of exclusion. So we're going to call this long COVID. And again, there may be some uncomfortable feelings in the chest when you're breathing, some exercise intolerance. It could be a chronic cough, fatigue, all the symptoms that we had mentioned. How do you treat those symptoms?
Yeah, so we'll treat based on what the history is and what the workup is. History is very important. As mentioned, a lot of children that I have in my clinic either maybe have an undiagnosed inflammatory airway process, such as childhood asthma, or some type of allergic process in the lungs that could be treated with a breathing medication. We'll typically do, in our lab, we do also, with the pulmonary function testing, we do what is called pre and post bronchodilator challenge, where we actually give them some albuterol to help open up their lungs to see if there's any significant change. And we can also send children home with an inhaled corticosteroid, such as Flovent, which is the same steroid that's in Flonase for your nose. It's relatively safe, no side effects. We use it in our premature babies. And we do that for a trial of maybe 1 month to see if there's any improvement with symptoms.
Yeah. And this doesn't necessarily mean that these kids are going to have asthma the rest of their life, right? I mean, that's always a possibility, especially if you have a strong family history of asthma. But for a lot of these kids, it really is just during that period when they kind of have that hyperinflammatory state in their lungs, right?
Yeah, and I use it as describing as kind of just resetting the lungs, getting them back to a neutral state. Trying this medication for maybe 1, 3, 6 months. Typically within a year, we have the children off the medication and they're doing just fine.
Great. And then in terms of getting back to school and sports, I know a lot of kids are very passionate, especially with sports, and want to get back into it just as fast as they can. Is that something that really needs to be done gradually, or can kids fight through this?
Really, there's no limitation for my aspect of things once we have good control, if symptoms are well managed with the breathing medication. Of course, if we notice anything abnormal with the 6-minute walk test where we refer to cardiology, typically we'll hold off on strenuous activity until they're cleared by cardiology.
Gotcha. And then, of course, as they are gradually returning to school and sports, getting athletic trainers and maybe sports medicine involved in terms of rehabilitation and get you back up to cardiovascular health and strength training and all of those things, it might be helpful to see them as well in the future.
Yeah, and some components that we offer here in our hospital to help with this, because I've had patients that are competitive swimmers, competitive athletes. We offer pulmonary rehab, which is a service with our respiratory therapist where we do different activities, different exercises to kind of build up their strength and tolerance. And we actually test during that time to see desaturations, difference in lung function testing. And I even know that I've had some patients kind of further out in the community, such as Mansfield, where we do offer those services out locally.
Yeah. And then is there a way to prevent long COVID from happening in the first place? Is there anything that you can do after a COVID infection to prevent this from occurring?
The biggest thing you can do is just promote vaccination. That's the biggest thing that we can do. Really no strong correlation between having an infection versus developing long COVID. Of course, if we've had a more severe disease or if we've had long COVID before and we have a return of active disease, there's always an increased chance that you could have return of long COVID symptoms.
Yeah. So it's more likely you'll have long COVID if you had severe disease, but it's still possible even with a mild infection that you could go on to develop long COVID.
Exactly, yes.
Yeah. And then you talked about this being a finite period. I just want to revisit that really quick. So folks who are impacted by long COVID, there is hope, right? That this is going to get better.
Yeah. I mean, the prognosis for this condition is very good. Most recover within 1 to 5 months, and a majority of symptoms don't actually persist longer than 12 weeks.
And then how do we treat long COVID here at Nationwide Children's Hospital? You mentioned that we have a COVID clinic. So my concern would be I have long COVID. Are there people with acute COVID infections in the COVID clinic? Am I going to be more likely to get exposed to COVID if I come in?
No. This is, by one of the definitions that we follow, it's post-viral clearance. So this is not an acute disease process. So this is someone that we see 6 to 8 weeks after an acute infection, where we evaluate, we work up, we broaden our differential if need be, and we kind of see what we need to do to treat the patient's symptoms and complaints that they're coming in for.
Okay, great. And then this is, I would imagine you'd mentioned it's a multidisciplinary process. You're seeing a pulmonologist to begin with, but you do have lots of other experts. You'd mentioned cardiologists. We've talked about sports medicine. I imagine if there's a mental health component to this, you probably get behavioral health involved as well.
Yeah. And with our COVID clinic, we have a mental health specialist with us. And so we give each family a questionnaire, one to the patient if they're able to complete it, as well as one to the parents too as well. COVID and treating COVID is a multi-specialty service. Here at this time, really in our post-COVID clinic in Pulmonary, it's just the pulmonologist and a mental health specialist. But depending on what we see and what our workup is, we work very closely with the cardiologist, we work very closely with the GI doctors, and going from there.
Yeah. I'm going to put a link in the show notes for this episode, 532 over at PediaCast.org, to pulmonary medicine at Nationwide Children's Hospital. And there is a link on that page to request an appointment. And both families and providers can request appointments. If your insurance requires a referral, then you guys would coordinate with the person's primary care doctor to help facilitate that, right?
Exactly, yeah.
Yeah. So folks can find that very easily. And then that page is interesting because, of course, with pulmonary medicine at Nationwide Children's, you're not just treating long COVID. You guys take care of lots of conditions. What are some of the other things that you treat?
Yeah. So we treat a huge spectrum of different conditions. Our bread and butter is cystic fibrosis. Thankfully, with advances in modern medicine, that is becoming less and less, which is awesome. We also treat severe and difficult to treat asthma. We also treat general pulmonary, chronic cough, primary ciliary dyskinesia, interstitial lung disease, electric vaping associated lung injury. And so we treat a huge variety of different things, including neuromuscular too as well. And most of our clinics are joint with other subspecialties, including neurologists, ears, nose, and throat doctors in our aerodigestive clinic. And as long COVID continues, or if it persists, this would be something that we hope to actually have a combined clinic with other services too as well, like cardiology, like neurology for brain fog, like GI for GI complaints.
Yeah, absolutely. Very, very interesting. I'm going to put you on the spot here really quickly. You mentioned vaping lung injuries, and you were here a couple of years ago, and we talked about e-cigarettes and vaping and the dangers that can pose to the lungs. My question is, during the pandemic, I think we had mentioned that there was sort of this epidemic of vaping that maybe improved a little bit as people were staying home. Now that folks are out and about again and back in school, are you seeing that ramping back up to pre-pandemic levels?
I wouldn't say it's at pre-pandemic levels yet, but I definitely have noticed an increase too as well. With the vaping epidemic or problem that was occurring right before the pandemic in 2019, a lot of it was related with school and sharing the different cartridges and pods between peers. With the pandemic and social isolation, obviously that social structure was removed, and so there wasn't that type of interaction. And so the vaping problem did improve, if not drastically, and now we're kind of seeing it on the uptick again.
Yeah, unfortunately. So just a reminder to folks, and I will find that episode and put a link to it in the show notes. So if you're listening to this now and you're like, oh, there was a vaping e-cigarette lung damage episode, yes, there was. And I'll put a link to it in the show notes for this episode so you can find it easily if you do have that interest. Once again, there'll be a link to Pulmonary Medicine at Nationwide Children's, and then some blog posts from our 700 Children's blog. One of them is Researchers Study Long-Term Effects of COVID-19 in Young People, what you should know about long COVID, and practical recommendations for long COVID in children. Those are all three 700 Children's blog posts, and we'll put links to those in the show notes as well. So Dr. Eric Mull with Pulmonary Medicine at Nationwide Children's Hospital, thank you so much for stopping by and sharing your expertise with us today.
Yeah, thank you for having me.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast a part of it. Really do appreciate that. Also, thanks to our guest this week, Dr. Eric Mull with Pulmonary Medicine at Nationwide Children's Hospital. Don't forget, you can find us wherever podcasts are found. PediaCast is in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCast.org. You'll find our entire archive of past programs there, show notes for each of the episodes, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. I also want to remind you, we do have a sibling podcast called PediaCast CME. That stands for Continuing Medical Education. It's similar to this program. We do turn the science up a couple notches and offer free Category 1 Continuing Medical Education credit for those who listen. And that's not just for physicians. We also offer continuing education credit to nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And that's because Nationwide Children's is jointly accredited by all of those professional organizations. So it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of the episode matches your scope of practice. Shows and details are available at the landing site for that program, PediaCastCME.org. You can also listen wherever podcasts are found. Simply search for PediaCast CME. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay safe, stay healthy, and stay involved with your kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast.